present a case of a 67-year-old female who presented having had treatment elsewhere for a non-healing corneal ulcer. She was treated for geographic ulcer of hepatic origin and keratouveitis as well. As you can see, the eye is chronically inflamed and was treated with a lot of intensive anti-inflammatories as well as autologous serum. And the cornea did heal, as formed the scar as shown here just paracentrally. There's a lot of neovascularization in superior limbus particularly, and also some scleral thinning. The side point incision was started off at about 12 o'clock. And over here you can see I'm using the viscoelastic cannula to try and get under the pupil to enlarge it, with not much success. The 2.2mm clear corneal incision was made and filled with the viscoelastic to deepen the AC. And these eyes with chronic inflammation tend to form a significant pupillary membrane which you have to remove. So over here it's as if I'm using the CCC forceps to create a capsulorhexis, but in actual fact just removing that pupillary membrane. The second hand is used to refill the eye with viscoelastic to create space to work. With the pupillary membrane successfully removed, the pupil is now enlarged with the good old trusted iris hooks as shown here. 4 hooks have been placed to enlarge the pupil, and vision blue is used to visualize the anterior capsule. In this case, with the viscoelastic in place, the vision blue has to be painted onto the anterior capsule. The CCC is started off with the capsulorhexis forceps, and care is taken when tearing underneath the area of scar not to lose complete visualization of the edge of the rhexis. As you can see here, several regrafts are necessary to control the propagation of the rhexis, and this was completed successfully here. I like to perform a hydrodissection with a 27 gauge flat tip cannula, and this allows the cannula to be able to get under the anterior capsule, particularly in these dense cataracts, without pushing too much on the nucleus. After I have hydrodissected, it is my practice to actually use 2 instruments to ensure that the nucleus is free and mobile as shown just now. And I start off with my sculpting. As you see here, the settings that I use for sculpting are shown on the screen in the bottom right. And I'm a stop and chop surgeon, so sculpting is done purposefully and slowly to go as deep as you can to create an initial crack. I then use a bimanual rotation technique to then deepen the groove at the other 180 position to ensure I get an equal crack down to the equal depths of the nucleus. Move on to the quadrant removal mode, and my settings are again shown in the bottom right corner. I tend to do a combination of vertical and horizontal chop, keeping view of the tip of the chopper at all times. I find that particularly in these small pupils, even though you've enlarged them sufficiently, keeping the view of your chopper tip is useful to not engage the capsulorhexis accidentally and create an anterior capsular tear. Care is taken to take your time to ensure that you're working at the pupillary plane, particularly with these dense cataracts, as you may cause either significant corneal edema if you're working too anteriorly, or you might damage iris tissue if you're not careful. You can do as many chops as you require to get the nucleus out. And what we tend to do is, when I reach towards the end of the last pieces of the dense nucleus, I tend to switch my second instrument to a flat tip instrument here as shown, which acts as a protector to prevent the PC from trampolining upwards towards my phaco tip. You'll find that in these dense nuclei, the capsular bag is often distended and could be floppy. And even though these newer machines give you very stable anterior chambers, you can never be too safe, and it's become my common practice to have the second instrument when I remove the last piece to ensure that the capsule does not come towards my phaco port. As you will see here, the anterior chamber is very stable and there is no trampolining of the PC. But this additional step, particularly when doing these complex cases, is something that gives me more confidence that PCR will not occur. The other added advantage is for the epinuclear plate as seen here. I'm using very gradual aspiration without using too much phaco energy, just to tease the remaining pieces with the second instrument into the phaco port. Having now removed all the dense nuclear material, I keep the anterior chamber stable with some viscoelastic with the second hand. Moving on to the INA of the cortex now, I have a bimanual technique which I have presented before, but using the coaxial IA handpiece together with a mini aspirator in the second hand, and this system is all linked up with a three-way tap that allows a switching of aspiration from either the main handpiece or the mini aspirator. What I find useful is the mini aspirator allows me to go sub-incisionally, and with the bimanual technique you get to use the other instrument to crush or tease coating material into the various ports. Again, maintaining anterior chamber stability, I like to keep viscoelastic filling the bag before I come out. In this case, a one-piece acrylic hydrophobic lens was used, and this is with the AutoCert. You can't quite see it here, but there's very smooth delivery of the lens with a wound-assisted technique through the 2.2mm incision. The IA is now done to remove the viscoelastic, and again, common practice that we all do now is to go under the actual IOL to remove all viscoelastic, and this enables the IOL to sit nicely in the capsular bag at a good lens position. I tend to remove my iris hooks in this manner, keeping the anterior chamber formed with my IA handpiece and using this one-handed technique to remove the iris hooks. I find this particularly useful, and if I'm doing toric IOLs, in this case this is not a toric IOL, because in these small pupils, if I remove the IA handpiece, sometimes the AC shallows right at the end because all the viscoelastic has also been removed. And what happens, you tend to lose sight of your IOL markings. You're not sure whether they've rotated. So in this case, I ensure that the lens has stayed in place, and right at the end using some BSS to keep the eye inflated before I come out. So this is the end of the case. Thank you for your attention.